So I think Jeen's story is actually great.
Let's do it.
She doesn't have like the biggest story of like distance traveled, like from severe pain to XYZ, right? But I think she has a story that everybody needs to hear and that everybody needs. And what I mean by that is Jeen had intermittent issues, but she didn't trust her body.
Okay.
And so she didn't trust it to go and do the things that she loved because her back would go out on occasion. And so it wasn't severe. It wasn't like a constant chronic pain of like a 7 out of 10 or anything. But it was just like low grade pain all the time, instability. Rather than backpedal away from the pain and say that, oh, well, I can't do those things anymore because I'm getting old. She said, okay, I'm gonna figure out what's not working properly, and I'm gonna step into it and get it fixed so that I can do the things that I love. The most common perspective is people backpedal away from their dysfunction and their pain. And so they experience an issue, a joint issue, and rather than go, they experience a joint issue, usually with some pain. That's how they know they have a joint issue. And then they go, oh, something's wrong, I can't do that anymore. And so they step back away from it. The problem with that is that when you step back away from your lifestyle, you decrease the demands on your body and you get weaker. And then that pain and that joint dysfunction retracts back upon you. And then you encounter it again and you go, oh, I need to backpedal more. And it becomes this backpedaling game of running away from your pain and your dysfunction. And you end up backpedaling all the way into a corner until you can't walk and you can't go upstairs and your body just gets so dysfunctional. We see it play out all the time. People have been backpedaling for 10, 20, 30 years away from their dysfunction and away from their pain rather than stepping into it and going, okay, my body's telling me I have a problem somewhere. Let's look at it, let's find out what the problem is and solve it so that I can do the things that I love. That's an offensive strategy.
Yeah, gotcha.
Right?
And
the defensive strategy is backpedaling. And when Jeen came in, she said, well, I know what my problem is. I'm not mobile enough. I'm not flexible enough in these areas. And Jaylee was doing her consult and she goes, respectively, you're wrong. And
told her right off the jump.
Jeen just wore it like a champ. She's like,
good.
Okay, all right. Because she was unstable. She had weaknesses that were her real issue. She didn't have mobility problems. She had instability and weakness issues that were leading to those problems. And so, but the fact that she took an offensive strategy and didn't backpedal away from her dysfunction, she stepped into it, went on the offensive and said, okay, I'm gonna fix this so that I can live the lifestyle that I love. That's what's so powerful about Jeen's story. That's what I love.
Cool. When, the whole backpedaling thing, like I heard you mention that at the workshop too the other day, but like to someone who has to kind of stick in the pain or fight against it or be offensive, like what does that look like for someone? Like, because Jeen could have decided to kind of like, oh, that's too much for me, I'm gonna back off. So
she's in her 70s.
And some people could be like, there's certain things that seem like maybe I'm going too hard. Like, how do you define, what is too much, what is not enough? You know what I mean? Or even using her example for.
Yeah, generally speaking, letting pain be your guide is a good idea. You don't want to do things that are causing you pain because your body is sensing that there is a threat. Right. So listening to pain is a good idea, but being intentional, and what she did was she was intentional about seeking out the actual problem, which in her case was the joint dysfunction, okay? Seeking out the actual problem and solving it, not just going, oh, well, I need to be offensive, so I just need to garden more.
Oh, so
that's not going to get you there.
So it's not even just being more physical.
No.
It's not just the physical side. There's a whole nother.
Doing the things that are flaring you up is just going to keep flaring you up.
See,
So we're definitely not advocating to just keep doing the things that are flaring you up.
Gotcha, okay.
It's about stepping back, looking at your joints and the joint system that's problematic, and going, what's the real problem here? Is there joints that are not mobile enough? Are there joints that are too weak? Why is this area telling me there's a problem, right? Because pain problems are never where the pain is. They're always 3 to 5 joints removed.
Right.
Okay. And so what she did was she stepped back. She said, okay, I know I have a problem because I'm having pain. Okay. And so I don't trust the area. What do I need to do in order to solidify that area, take pressure off of that area, and then strengthen and get strong so that I can do the activities that I love?
Gotcha. Yeah, because in my mind, I was already thinking, okay, pushing against pain means doing more work.
That's
But
interesting.
Yeah.
Yeah.
But you're saying, no, actually being proactive is the start of doing something in the right direction, even if it's not specifically connected to being more physical or doing more workouts. It's not always that.
Yeah, 100%.
What did she come in for specifically?
Yeah, so low back instability.
Okay.
Her pelvis would go out, her back would go out, her SI joint would slip 4 or 5 times a year. And when she would go upstairs and when she tried to pick things up off the floor, it just felt unstable and she could feel that something wasn't right. And so she wasn't trusting her body to go do those things.
Right.
And so she came in and we had to shatter all the myths and the preconceptions about what she thought the problem was.
Right.
And then we just walked her through correcting her mobility issues, joint range of motion issues,
Cool.
finding those atrophied muscles that weren't stabilizing her pelvis, her ankles. And now she's deadlifting 80 pounds for 10
didn't know
reps.
that.
Like,
Cool.
she's in her 70s and she's just like crushing it. She's doing like asymmetrical planks and like just real athletic movements. And she came to me the other day and she goes, Matthew, you know I love you to death. You saved my life, right? I want to work a little harder. Do I need to? What do I need to do to like get some more athletic movements? And I'm like, Jeen, let's go.
Yeah,
So,
right.
like,
she's poking you to get more.
I'm like, all right, here we go. Let's do it.
Can you describe some of the moves? I mean, we talked a little bit about what, what kind of bar she's pushing now, but like what type of moves did she use or do when she first got in? Which is like, I mean, even for me coming in, like I'm watching people, I'm kind of doing some of the moves too. I'm like, and there's an overall experience to people when they first start, like thinking that the moves that they're doing may not be effective. Was that an experience for her? Or?
Yeah, because she was already exercising, right? She was doing what most people think of as good exercise for her body. Like she was going to yoga, and she was like going and like doing squats and like doing things that are supposed to be good for your body. Unfortunately, she just had certain atrophied muscles that weren't engaging during those movements, and so like the process when she first started was like, we have to get your glutes to engage. We have to get your glutes to fire. Glutes are one of the most atrophied muscles in our culture because we don't spend time in a deep squat position. We spend time seated.
Right.
And so the glutes just atrophy. It's just a cultural.
Why? I've never really asked you that. Why is it that they atrophy when you're seated? Is it just because you're like, I don't know if you could point to that, but is it like because you're sitting on them and there's pressure, no blood getting to them?
No, it's that the glutes are what's known as a phasic muscle, and they only engage during movement. Okay.
Okay.
And so, like standing here, your quads are engaged, right? Like your pecs and your traps are engaged, because if they weren't, you would just fall down, because they're holding you up.
Yeah.
They're maintaining a baseline tone.
Okay.
Okay. Feel your glutes.
Should we go over here?
I mean, I think you're fine. They're not firing.
Yeah, I guess they're not.
They're not.
Okay.
Okay. Only when you go out and you start to propel your body forward, i.e. running, some walking, but running, going up high steps, or going into a deep squat, do the glutes actually engage. Our lifestyles, our culture has been designed to remove high steps from our lifestyle, to remove deep squats from our lifestyle,
Right.
to make to make it easier for everybody to be able to live life, right? The problem with that ease and that convenience is that it comes at the expense of our glute function.
So it's not necessarily the fact that the sitting position is terrible. It's the fact that the glutes are just not being used.
It's the fact that it's sitting in a chair has replaced squatting.
Gotcha.
Because historically people have squatted and spent more time in a deep squat position. And we just don't do that anymore. And so our glutes just culturally don't have an opportunity to turn on anymore. So everybody is battling glute atrophy. Everybody. Yeah. And so going back to Jeen, she had to learn and go through the process of retraining her glute to fire, and all those muscles that were compensating had to be shut down. When you're walking through baby steps 1 through 5, okay, it's all about rewiring what muscles are firing and when. So it's all a nervous system adaptation. And so the big one is that your glute isn't firing, and that your TFL muscle, and maybe some hamstring or some inner thigh, but okay, your glute isn't firing, and your TFL is firing too much. Okay, so you can see this when you're walking through the grocery store. If you watch people's gait, when their pelvis is shifting and it's not remaining level to the floor, when it's not remaining parallel to the floor, when you're getting that shift, that's called a Trendelenburg sign, and it's an indicator of a weak glute.
And that's coming from the tightness of the...
It's coming from atrophy through the glute and tightness through the TFL. Okay. And so basically what we have to do is we have to mobilize this area, massage it, go through active stretches, loaded stretches, static stretching, right? Any of those will do the job because we're wanting to shut that muscle down neurologically. Yeah. So shut that muscle down, and then we go into like a clamshell.
Can we show people like what that would be? Do you want me to get like a foam block for anything?
To roll the TFL?
Oh yeah, it doesn't matter, whatever you need.
I could probably just do an active stretch.
Cool.
Yeah. Cool. So when you're trying to deactivate a muscle, you can take it through you can do a static stretch. You can do an active stretch. Okay. For the sake of explanation today, we can just say if you take your hip flexor, that TFL, through an active stretch.
Yep.
Okay, 20 reps times 2, okay, and then you go into a clamshell, stack the hips forward, raise, lower, get above 45 degrees so that that glute will actually fire, okay, and if you're having a really hard time, you can just put it up and hold it with a band around there. Will increase some resistance, but you have to get that glute firing. That muscle's gonna wanna take over and do all the work. You have to get it to chill out, then get that muscle to fire.
And what's that chilling out process of the TFL? Like, how do you, like, let's say it's over engaged. What are you like paying attention to make sure you're just getting the glute action there on a clamshell?
Yeah, so if you put your hands here, you'll feel this muscle is contracting and getting really hard.
Yep.
Okay, that means that the TFL is dominating that movement. Whereas if you go into your clamshell and this is staying relaxed, the TFL is staying relaxed, and then your butt, back where your back pockets are, your glute muscles are contracting, they're hard. When you push on them, that means now they're doing the work. That means you fix that wiring pattern there on the lateral chain.
So you're paying attention literally to where you're feeling like the power or the strength, where you're sending the strength.
What's contracting, where you're sending strength is a great way of saying it. Yep.
Cool.
So for Jeen, that was everything, because when she was going into her squats at home, okay, she was doing these squats, but her knees were buckling in, and so she was doing this quad dominant squat.
Wait, how do you know that's quad dominant?
Because her knees are buckling in, and so your glutes can't fire when your femurs go into an internally rotated position.
Okay.
And so position dictates firing patterns.
That's good. Yeah, I like that.
So if your knee is buckling, your glute can't fire.
Gotcha.
Okay,
so
which is why when we're retraining squats, the first position that we train is actually a plie externally rotated position, because this puts the glute in an optimal position to contract after it's been in an atrophied state.
Whoa, cool. How many like Could you like shout out how much like reps maybe she did in the beginning? What the program was like, maybe some details of her in the beginning and then how it grew.
Yeah, so at first she was just lying on her back doing supine rowing.
See, I kind of want you to like show that part too, because I don't know. I mean, do people know that that's what you do to start?
I mean, them, probably not.
Yeah.
I mean, basically all you're doing is putting a chair under here, and we can link up in the video.
Oh yeah, that's a good idea.
But you just put a chair under here, okay, lay something on the outside of the foot so the foot doesn't roll out, and you just lay there for 10 minutes per side. And you're just going into deep relaxation and breathing.
And this is where the patience and, you know what I mean? Patience, kind of trusting the process, where like most people kind of like, what am I doing?
This is the step in the process where everyone goes, oh yeah, so you just want me to lay there and do nothing. And I'm like, no, I want you to lay there and let your overactive nervous system calm down.
Yeah, could you explain that a little bit?
Yeah,
I mean, like,
so when you deload, okay, when you go through an unloading or a deloading process, what you're doing is you are decreasing the demands on the structure, and so you're telling those muscles that it's okay to calm down. And so really what we're doing is we're taking it out to a mild stretch, 70, 80% of max range of motion, and we're leaving it there.
Yeah.
And we're not having them upright, because when you're upright, your muscles are contracting. And so get them laying down, super critical, okay? Just deactivate those muscles, 10 minutes per side, okay? And you're calming your nervous system. You're calming that muscle down and allowing it to lengthen, because it is getting abused with every single step. It is contracting 4 times as hard as it needs to with every single step on most people.
Really?
And so by unloading it and just giving it a break, we can calm it down, and then when we go into massaging it and rolling it with a ball and going into stretches, it doesn't fight back against us and hit what's known as a stretch reflex.
What's that? I never heard you talk about that.
So a stretch reflex is when you take a muscle to a stretch, okay, you ask it to lengthen, but the muscle and the nervous system sense a threat to tear, and so it's going to contract back against it.
Is that when you'll like stretch out or roll a glute, and you said sometimes you can like feel like something kind of moving around? Is that what you've mentioned, or is that something else?
No, it's more like if you go into a stretch, okay, and you don't actually feel any added range of motion afterwards, you can actually even feel tighter afterwards. So you can actually check if you hit a stretch reflex mathematically. You take a client to their range of motion, okay?
Yep.
You test it, and then you have them get up, walk around, take them into your stretch, and then come back and retest, and if they've lost range of motion,
then you know
you hit a stretch reflex and that you did absolutely no good for that client. Because you have to test and learn and see what their nervous system is going to give you.
Gotcha.
Because the nervous system rules all.
Yeah,
Okay?
which is like, I'm still trying to wrap my head around the nervous system.
The nervous system is the brain and the peripheral nervous system, and so the brain is telling the muscles how much to contract. Okay? And so your brain is trying to keep your muscles safe. And so if you take it to a max stretch and your brain is going, no, that's not safe, it's going to contract it and shorten it, because a muscle is most likely to tear when it's at its max stretch.
Oh,
so your brain is trying to
protection
protect.
mechanism.
Yes, it's a protection mechanism. And so the problem with always staying in a fight or flight in a protection mechanism standpoint is you never actually get those muscles to lengthen or relax. And when one muscle is contracted, the other muscle on the other side of the joint is always deactivated.
Okay, so like now it kind of makes sense. The deactivation makes a little more sense. So when you start putting, let's say, the TFL under kind of just a steady, stretch, instead of it panicking, you're saying it's okay for it to be here. Oh,
so we're taking it to 70, 80% of your max range of motion, not enough to trigger, not enough to freak out your nervous system, okay? But enough to put it onto a stretch and then let your nervous system know it's okay. It's all right.
It's
relax. And then we encourage breathing, because that's going to be another signal for your nervous system that it is safe.
This is good.
And so we can, step 1, which is those deactivations, prepares your body to then take your muscle to 85 to 90% max range of motion, stretch.
Gotcha.
Okay, which prepares your body for loaded stretching. So now you can use loads and take it to max range of motion without your body freaking out. And so it's progressive overload.
Dang, okay. Just consistently asking permission.
Asking permission is a really important term.
Yeah.
Because your nervous system rules all, right? And so you can't go, oh, well, I want my joint to move more, so I'm gonna force it. Yeah. Your body will go, no, 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 no. I run the show around here. That doesn't feel safe to me, and it'll just tighten down.
Gotcha.
And so when you're trying to gain more joint range of motion, you really are asking for permission on every rep and every stretch. And so what we do is we tell people, I want you to breathe and exhale, okay? Because your breathing and your muscle contractions are intrinsically linked.
Oh boy.
Okay? So when you feel scared, okay, what happens?
I mean, I probably close up, start breathing more.
You tighten up and you shorten your breathing.
Yep.
Okay? And so your diaphragm stays contracted or hold your breath, right? And so your breathing and your muscle contractions, okay, how tense you are, those two things are intrinsically linked.
Okay.
Okay? So what we're trying to do is get you into your rest and digest nervous system, okay, out of your fight and flight nervous system, and that's going to allow more joint range of motion and less stretch reflex when we ask for permission for more joint range of motion.
I like it.
And that's really crucial because that allows us to get to getting that atrophied muscle to fire. Because you can't just ask an atrophied muscle to fire because there's other muscles that have been doing that job that are just going to keep doing that job. That's why gardening doesn't fix anything.
Right.
Because it's the movement that you've been compensating with. You're not going to fix a compensation by doing the very things that you've been compensating with. Okay, and so it takes a very specific step-by-step protocol of releasing and mobilizing and calming down those overactive compensating muscles, and then very specifically targeting, engaging, and contracting and confirming that you're contracting those atrophied muscles. So that was huge in Jeen's case. She didn't realize her glutes weren't firing.
Right.
And then once she started realizing that they weren't firing, she had to figure out how to get them to fire. And it's not like a conscious thing. You can't control consciously what muscles are firing and what muscles aren't firing.
Not even if you're just like...
Not even close. Because it's regulated by your midbrain and brainstem, which is the same areas of the brain that regulate breathing and heart rate and digestion. You can't stop your digestion. If I was like, focus really hard and stop your digestion, you'd be like, no, I got it.
Yeah.
So it's the same thing. It's the same area of your brain that regulates posture and movement. You don't have access to it.
It's so interesting. In my mind, I'm thinking, I have complete control over what I want to fire and what I don't. But you're telling me...
That's an illusion. You do not.
Okay. All right.
So once Jeen got her clamshells really strong, her glute muscle really strong, then it was a process of just building her strength and her load-bearing capacity. Very step-by-step progressionally, 5% per week, okay? And taking
Could you explain what a 5%, like, is that just like, is that 10 reps to 15, or what do you mean by that?
Yeah. So if the demand is, if we're asking her to do a plie sit stand, right? So she's sitting down into a chair and then standing up. Okay. If she weighs about 150 pounds, okay, she's going to be moving or leveraging the load of here up, which is going to be about 135 pounds.
Okay.
Okay. And then if I put a 10-pound dumbbell in her, or 15 or 20, right? That's going to put her up at about 140, 150 pounds. Let's just say 150 pounds for ease of calculation.
Cool.
Okay. So we don't want to take her from a 150-pound load to a 200-pound load.
Right.
Because that's a 33% increase overnight. Her tissues will break down under that big of a load. It's too big of an ask.
Gotcha.
Okay. And so taking an incremental increase in load and applying that to the structure, the tissues will actually reconfigure, get more organized, more dense, and more capable of bearing load, which is what getting stronger means.
Okay.
And so Jeen went from doing sit stands with body weight, getting the proper muscles firing, to then progressionally increasing load, to then going and learning how to hip hinge, which is a whole thing in and of itself. And now she's deadlifting 80 pounds for 10 reps. Step by step by step by step by step by step.
Yes. How did she do throughout the whole span? Like, how long was she here? Or in the kind of getting her back to strong?
She's been here about a year, I think. Usually the process takes about 6 months.
Cool.
Okay. And I think the thing that Jeen did so wisely was she asked questions along the way.
Really?
She is one of my best students in terms of asking questions and seeking understanding. She doesn't want to just be told what to do.
Yes.
She's stepped into a place of stewardship of her body, and she wants to be able to know, why am I doing what you're asking me to do? I know you have a reason. I know there's a method behind it, and I want to understand it because this is my body, and she stepped into stewardship of it, which is one of our core values for our clients, is getting them to take ownership and stewardship of their body, and she's really stepped into that. And she's challenged me on things.
Really?
Yeah, it's
so
great.
What did that look like? Would that look like, hey, this move seems ridiculous, why should I do this? Or is it more like...
It's more like deadlifting, right? She's like, I'm 70, I'm probably gonna get it wrong, 73, 74, something like that. I don't need to be deadlifting 40, 50, 60 pounds, 70 pounds, 80 pounds. I'm not trying to be a power lifter. And I'm like, fair enough, fair enough, okay. And so then basically what we did was we just went through a process of going, what do you want your lifestyle to look like? At what point do you want to get hurt out in the world, and what do you want your limit to be? Because that's when we get hurt, when we step past our limit of our load-bearing capacity. Okay? And so I asked her, at what point do you want to get hurt, right? Is that lifting a bag of dog food?
Got you.
Is that, like, what's the limit?
The threshold. You're like creating a threshold to get
Creating a threshold, and then just you have to know that you can't step past that.
Cool.
Okay? And so for her, it was like, well, I want to be able to pick up a case of water bottles. Okay? I want to be able to pick up a bag of garden soil. Okay? And I'm like, okay, bag of garden soil, 40 pounds maybe? I don't know. But here's the thing. 80 pounds deadlifted with perfect form is very similar to 20 pounds lifted asymmetrically or unevenly.
I didn't know that.
Okay, so think about it from a physics perspective. This cup is going to be very light right here when it's close to me.
Right.
It gets 10 times heavier when it gets farther away from me.
Right.
So if you want to pick up 20, 30, 40 pounds regularly, okay,
yeah,
what happens that one time when you pick it up an extra inch or 2 inches away from your body not thinking about it? That 40 pounds becomes 100 pounds instantly. And so you need to be strong enough in here to live your life out there and not get hurt.
Well, how did she take that information? She's like,
great, I'm all in. Let's do it.
It sounds great.
She's like, because I never thought of it that way.
Yeah.
I never did the math on if I pick something up off center or away from my body, what does that do to the mathematics of it?
That's cool.
Right? Because if there's 200 pounds of load on your low back when you pick something up symmetrically, right, and close to you, right, that means there's 100 pounds on each side of your spinal erectors, on each side of your spine.
Yeah.
Okay? So if your spine is here, each muscle is holding up 100 pounds. Okay? Well, what if you pick it up 1 inch off center?
I don't know. How much more is that?
All 200 pounds goes to one side. And so you've doubled the load on one side of your spinal erectors, and people go, well, I don't want to be that strong. I don't need to be that strong. I'm like, you have no idea how strong you actually need to be.
Yeah.
And I don't even know. I don't know what movement you're going to do.
That's true.
You know, because if you pick something up 6 inches out in front of you and it's more heavy than you think, it's going to be 1,000 pounds of load directly to your lumbar spine. Like, easy. You can get to 1,000 pounds of load. And so understanding you need to be as strong as possible in here, done safely, of course.
Right.
So that way when you encounter the unexpected out there, you're prepared for it.
Right.
And then also learning so you can minimize the unexpected out there because you understand the mathematics of lifting.
Right. Which, I mean, you've talked about that before. I mean, what do you call the aspect that is like the math behind it moving off center? Like, what is that? Is that just pure physics?
Yeah. Yeah.
Which is like
all the stuff that regulates normal everyday life.
Yeah.
Math is the language of the world.
Yeah.
Yeah.
I mean, I don't think of things that I do on that level, on a physics level.
Sure.
Because I think a lot of times when you're like working out just regularly, you're thinking best case scenario, I can lift this thing, you know what I'm saying? In a perfect, if everything is perfect and everything stayed right here, but essentially what you're saying is like, no, we need to define what you want to be able to do and even kind of go and think about potential
mathematical
demands.
situations.
Yeah, demands you're asking your body to
100%.
go for.
Well, and even in here, it's important. So like people work with coaches and trainers, and those trainers aren't thinking mathematically, and they just have no idea the forces that they're applying to their clients. They're just completely clueless.
Right.
An example was like Jeen was doing like a straight arm pullover with weights. Okay, like laying on her back.
Oh, okay, yeah.
And she was using like an 8 or a 10 pound dumbbell. And then I said, go grab a 30 and come over here. And she's like, a 30? There's no way. I can't move a 30. I was just struggling with the 8. And we were doing a single arm row, which is a very biomechanically advantaged position.
That's where you're like kneeling over the bench, right?
Yeah, where you're parallel with the floor and you're pulling into your side.
Gotcha.
And she did it, and she's like, I can do it no problem. How did you know that I could do it no problem? I said, because you were lifting a 10 inches away from your body.
Yeah.
Okay, which is 10 times 10, it's 100.
Right.
Okay, so you're lifting 100 pounds of load. Okay, now you're doing 30 pounds in line with your shoulder. Right. So it's just 30 pounds. Right. It's less load than the 10 because it's all mathematics. Everything breaks down to math.
Well, we're not, yeah, I guess the lesson there that you're trying to figure out too is the number on the weight itself is not necessarily the impact that it's having on your body, right? Is
100%.
What you're getting at.
Yeah, because it's, the bigger variable is how and where are you moving it with your body.
Yes, like where you're putting the pressure or wherever the demand is like going to on your body.
Yep, let's do some Q&A. This is fun.
Okay.
I like it.
Something, I know we chatted about this before, but the whole like, is pain in certain body areas genetic? so like I told you with me, like I have problems in my back, and I'm like, hey, my dad has problems in his back. My brother has problem in his back. We must have like a genetic problem.
Genetic back problem.
Yeah.
Yeah.
And then I was thinking with like other pain areas, I'm sure you've heard it before, knees, hips, other places. So I would just like to open the can of worms and see what you think about all of that. Feel free to get into as much as you want.
All right. Genetics. Genetics is the greatest scapegoat in our world.
Just because we don't know what else is happening.
Because we don't know, and so there's a black box, right? Most people look at their body and there's like a black box. They don't know what's happening in the black box, and then they try to make sense of it by seeing what's not in the black box, which is my mom had a bad back, and now I have a bad back. Right. So those two things must be linked, but they didn't actually open it up and go, oh, there's a lot more inside that box than I ever thought. And so why do you have a bad back and why does your dad have a bad back?
Yes.
Well, the thing is, everybody has bad backs. And so you are not unique in that you and your father had a bad back. Culturally, Everybody has bad backs. And so, and the reason for that is because it's culturally driven. And so we talked about this a little bit earlier. Culturally, we are prone to glute atrophy.
Right.
Okay, we are prone to ankle instability and atrophy. We're prone to our ankles and big toes not moving enough.
Yes.
Okay, so here's the thing. You and your dad both sat in a chair a lot, right? You and your dad both wore shoes.
Yep.
Okay, that cramped your feet and distorted the way that your feet work so that your feet look more like shoes than they do feet, right? And so you've lost arch stability, you've lost ankle stability, you've lost glute function. All of those things transfer load up into the low back.
Right.
And so you had a low back problem, right? In reality, you had a big toe, arch, ankle, and hip problem that just transferred load to your low back. Problems aren't where symptoms occur. The reason that the back is the problem is because that's where the load is landing.
Right.
Okay, and so it's not that you and your dad both had a bad low back, it's that culturally we all have bad low backs because we spend time sitting, we shape our feet to look more like shoes than feet, and so everybody ends up with a bad low back, the same way everybody ends up with knee replacements. It's a cultural phenomenon, not a genetic phenomenon.
So that's the kind of myth buster of that idea. And you mean you could point it, I almost wonder if you should either repeat that or show it. But it's like, just to reiterate again, it's like the low back is, if it's screaming at me in pain, it's not necessarily that's the thing, that's the problem. And you've talked about that before too. It's like
the area of pain is it's never where the problem actually is. So the pain itself is not the problem. It is your body's fire alarm system telling you that there is a problem somewhere. Okay. The area of pain, say the low back, is not the problem. That's where load is landing. Okay, but dysfunction elsewhere is shoving load and compensation into the low back. So the real problem is occurring at the hips, at the knees, at the ankles, at the feet, at the big toes. Those are problems. The low back is the victim. Most people come in and they say, oh, well, I have a low back problem, and we have to break that to pieces and go, okay, you have low back pain, you have dysfunctional joints below that the low back is resting upon. Okay, so for you, your hips were subluxed. You had a dislocated SI joint. So where your hip connected to your spine was actually dislocated out of place. This is super common, and what happens is you get a nervous system reaction and muscle spasm in the low back because it's trying to stabilize your hips, but that's a hip problem, that's not a low back problem. So that's just one thing, okay? Unstable SI joint because of atrophied glutes.
Yeah, you were telling me about that too. I want you to explain that, because atrophied glutes meant, you mentioned it, that it didn't keep the hips
stable.
Right, okay. So
Okay.
and that's what the glutes are there to do.
The glutes are meant to stabilize the pelvis, okay, and propel the body forward. And so when we walk, our pelvis, our belt line should remain level to the floor. But when our glutes atrophy, we get this sort of like what people call like a model walk where their hips are swaying back and forth, right? Biomechanically, that's an absolute disaster. What's happening is when that pelvis drops,
what happens
when that
then?
pelvis drops, this muscle up here is getting put on a stretch, and then it's holding on for dear life trying to stabilize this pelvis, but the problem is over here. So a weak glute on this side creates a low back problem on this side because this side is compensating and trying to do the work of this glute, but it's 1/8 size. It's tiny compared to this big glute muscle. There's no way it can stand up to that load.
Interesting.
Okay, because the pelvis wants to hold the body wants to hold the pelvis level.
Okay.
And so if it can't hold the pelvis level from this attachment,
Yep.
which is where it should be, it's going to try to hold it level from
there.
this attachment.
Holy smokes.
So people go, oh, I just have a
Wait.
chronically tight low back. And so they go to their massage therapist, and their massage therapist just rips into their low back, trying to release the low back. It's not a low back problem. Chronic tightnesses always have their roots in chronic weaknesses elsewhere.
Every time?
Every time.
One more time. Okay. One more time.
Hit me with it.
So if this is atrophied,
Yep.
this doesn't have the ability to keep it in place. So this is taking over? Mm-hmm. I don't understand. Why is that?
So when this muscle applies contraction, force, okay, see what happens? It's pulling this side up.
Right.
Okay?
Yep.
Now, erase that. What happens when this contracts? It pulls this side up.
Up, right.
They both serve the same function, and so if the primary muscle isn't doing its job, the secondary muscle is going to have to try to do it.
I get it now. Okay.
And so that's a disaster.
That's insane. So this is trying to tighten to level out the atrophied muscle here.
Mm-hmm. So wherever there is a chronically tight area, ignore it. Go and find the chronically weak area, fix that, and then the chronically tight area dissolves and dissipates and relaxes all on its own. Same thing with the neck, same thing with the tennis elbow, same thing with the hips and the growing.
Go through that. Do you have an example of the neck doing the opposite thing?
So the neck
or elbow, it doesn't matter.
Yeah, the neck's a good one. So your shoulder blades, okay, your scapula should sit upright. They should point up toward the ceiling. Okay, look at so this is my shoulder blade, the top of it, okay, and the bottom of it is right there.
Yep.
Okay, so bottom, top, where's it pointed?
Up, yeah.
Up, okay. Relax, put your hands down by your sides. Thank you for doing this. Yours are pointed this way. Okay, so why does that matter?
Yeah.
Okay, when this muscle under here gets weak, called your serratus anterior, that muscle is responsible for holding your shoulder blade upright. When that muscle gets weak, this muscle gets tight, and so our trap starts doing all the work of shoulder blade stabilization instead of sharing it with your rotator cuff, your mid-back, and your serratus anterior muscle.
How is this taking more load? Muscle-wise.
Mm-hmm. Because the scapula stabilizers. Think of all joints work within systems.
Okay.
Okay. So the traps, okay, your neck muscles. All right. Your rotator cuff, the muscles that do that.
Right.
Okay. Your rotator cuff, your rhomboids, and your serratus anterior muscle, all are responsible for stabilizing and controlling your scapula. Okay? So they all share the same job.
Interesting.
Okay? Now, if this atrophies, and this atrophies, what now has to do 4 people's jobs rather than 1 person's job?
Just that.
The neck muscles. And so every time you press, every time you pull, every time you reach, instead of having 4 muscles that are doing the job of scapula stabilization, you have 1 muscle that's doing everything, and it's just all up in your traps all the time, and everybody has a tight neck, and everybody goes to the massage therapist, and everybody buys a Theragun, and everybody puts Icy Hot on it, everybody takes ibuprofen, but nobody's actually looking at the real problem, which is that 1 muscle is doing the work of 3 different muscles that are just checked out. They're completely atrophied.
So back to the question of sometimes you mentioned not going after the tight muscle, but going after the atrophied muscle. How do you identify, so this would be my tight muscle, how do you go after the other parts to loosen?
Yeah, it's walking through the baby steps. The baby steps work every single time. So it's deactivate. Okay, so we're going to deactivate these tight muscles, static back, deload, take the weight of your head off. Okay. Then we'll go through and mobilize, shut this area down, shut this area down.
Deactivation, can you give one exercise that is connected to that?
Static back.
And that's laying on the ground?
Legs up in the air, chin tucked, just relaxing and doing deep breathing.
For
20 minutes.
20 minutes, yeah.
Yep.
Cool. And then,
Then you go into mobilizations, massage, active stretching, static stretching for pecs, traps. Okay, open it up so that we can restore position back. Then you go in and you activate these atrophied muscles, external rotator cuff, scapular retractors, serratus anterior, which is a scapula protractor. Okay, so you go in and very specifically target these atrophied muscles, get them firing again. That holds your shoulder blades upright, and now the work is now shared by 4 muscles rather than all done by one.
and that's where you finally get relief.
And that's when you get relief for the neck.
That's crazy. And just to be super obvious, I mean, that's what you guys do here. I
Yep.
mean, that journey.
Yep.
Yeah. Is there anything else to touch on with the whole genetic, you know,
Yeah, I mean,
misconception?
so, yeah, it's a huge misconception, okay? If there is any really knowledgeable people out there, they might raise their hand, and this will be the one objection.
Okay, go.
Okay? Your annular wall of your disc, so the disc between your vertebrae, okay, you have vertebrae disc, the marshmallowy thing in the middle. The wall, the annular wall of that, it has a genetic component. Okay? So some people have a genetic marker that they will have a thinner annular wall, which makes them more prone to degenerative disc disease. Okay? Here's why that doesn't matter. Because I'm arguing with myself now.
Hey, you're not arguing with me. You're not arguing with me because I have no clue.
Here's why that doesn't matter. 80% of the people 55 and up are walking around with degenerative disc disease and 0 pain.
Yes.
Completely asymptomatic. And so degeneration is only loosely correlated to pain because structure and pain signals are 2 completely different systems. One is in the bones and the cartilage and the muscles. One is in the nervous system. And those 2 things will touch each other, but they are 2 distinct systems. That's a whole nother conversation.
I know. I'm like, do we get into it right now? Do we get into it right now?
You do not have to fix all of your structural problems in order to get out of pain. You just
Whoa.
don't. You
Whoa,
can
that's
calm
interesting.
your nervous system, decrease your body's sense that there is a threat, and get out of pain, because all the research has shown that you can have structural damage, and we all do, we're all walking around with it. We can have structural damage and be completely pain-free, because pain exists in the nervous system, in the brain and the peripheral nervous system, and our interpretation of that issue. Okay? But it is not a direct response to that issue. You do not have to fix structural issues in order to get out of pain. There are some certain structural problems that have high correlations to pain,
Like?
in which case it makes sense to have surgery. Severe bone-on-bone knees that are now unstable. Severe spinal stenosis where you're impinging on your spinal cord. Those are no-brainers. Go get surgery on that, clear that up. But the myth that structural changes, structural degeneration is what's causing my pain is completely broken. There's no causal relationship with there. It is loosely correlated at best.
That's crazy. Just to be super obvious about the other side. So what are some common, or what are places people are, you know, mentioning they have pain that can be resolved through just the nervous system? I know that'll be obvious to you, but like just for people.
I mean, you're talking about like what structural degeneration?
No, I'm saying like what are things people are coming in for that they're like, this can be, you could be pain free just by fixing, kind of calming the nervous system. Mm-hmm. Like what types of?
Every single joint issue on the human body. Feet pain, ankle pain, knee pain, back pain. Honestly, the biggest ones are centralized spine pain. Neck, mid-back, low back. Centralized spine pain, meaning it's not radiculopathy going down the arm or radiculopathy going down the leg, but centralized pain near your spine is the most complex condition with the most multifactorial conditions, and so having surgery on those is an absolute nightmare because the surgeon has no idea what's actually causing your pain. So they're just like flipping a coin going, is this gonna work or is this not gonna work? There's good surgeons out there who have good filters to make decisions through. It's not that all surgeons are clueless, that they're super smart. But a lot of them will turn people away and go, there's nothing that I can personally do for you. You need to go chase down other avenues. And that looks like fixing the biomechanical problems, calming your nervous system, reducing inflammation with eating good food, drinking, getting hydrated, all that kind of stuff.
Gotcha. So the people are not stuck in chronic pain. People are lost in chronic pain. You've noted it's a navigation issue. And so I think what would be kind of cool is to have you kind of speak on it a little more, but also maybe describe what that feeling lost may feel like to people, but also maybe even your own experience, because I mean, you building a line was a part of that experience too, right?
I spent 12 years in severe chronic pain, opiates for 10 of those years, under the skin morphine pump, pain pump.
Wait, hold on, under the skin, what is that?
It's just a little drip.
It's like a drip, okay.
Yeah. And 4 surgeries, most of my lumbar spine is fused. I mean, just more physical therapy, chiropractic, massage.
And you should share how that happened.
Yeah. PE class in high school was doing a back squat and broke my back in 3 places, tore a disc, had nerve damage out of my L5, S1 nerve root. Just created a mess. But it took 12 years to fix it. If I would have come to me now, it would have taken me 12 to 18 months to fix it. So I spent 12 years in pain because I didn't know how to navigate it.
Yeah.
When in reality, I needed to spend 12 months in that pain.
So describe what feeling lost for 12 years feels like.
It's rough.
Yeah.
It's rough.
That's what some people are dealing with coming in, right?
Yeah, 100%. It just feels like loss and like suffocation. All of the things that make you who you are get stripped away in chronic pain. And statistically, they found out that the likelihood that you will be depressed while in pain is directly correlated to how many activities that you love were lost.
Whoa. So like passions, hobbies.
Because those things, whether we want to admit it or not, they make us who we are. They're part of our identity.
Yep.
And they bring us joy. And when those things are stripped away, there's a real loss to that. And so when people are going through pain, it starts out like, okay, well, I can't do that as often, right? And then it gets worse and they're like, I can't do that anymore. I can't golf anymore. I can't go out and garden, and I can't, pick up my kids, and I can't, these things are real losses because they make up who we envision ourselves to be, right? And so you feel lost and you just feel suffocated and you don't know if you're ever going to get out of this hell. And it's terrible.
Yeah.
And then you go to well-meaning professionals, massage therapist, chiropractor, surgeon, and they're all looking through the keyhole of their specialty, right? And so a massage therapist is going to find tight muscles to work on, inevitably, right? The chiropractor is going to find things that are out that need to be put back in. The surgeon is going to look at it from the perspective of, is there something for me to surgically fix here, right? But nobody's looking at it from the big puzzle. Nobody's looking at the whole picture, because the thing about pain is that it is, I don't want to stray too far from your original question, but the thing about pain is that it can have 30 different causes.
Right.
Okay, and so you can have one pain experience, pain, ow, back, right? But it could have a driver in my dysfunctional big toe, my weak ankle, okay, my unstable pelvis, That could start to cause degeneration in my low back, and so now I have some degenerative disc disease, I have some bone spurring, so now I'm up to like 5, 6 problems, right? Now I've been in pain for 3 months, 6 months, and so now my peripheral nervous system, okay, my spinal cord and all the things that attach to my spinal cord are starting to get sensitized, and they're starting to memorize that pain pattern. Once you've been in pain for a while, your nervous system memorizes that pain pattern, and even if the original problem is removed, that pain pattern is memorized and you will stay hurting.
What?
Okay, so now you have 7 issues, a memorized pain pattern that even if you fix all that stuff, the pain's still going to be there. And then you've been sensitizing your parietal lobe and your midbrain, which is where all those pain signals are getting routed and interpreted. And now those can become memorized pain patterns. Now you remove the actual problem, you still have a memorized pain pattern in your brain, in your peripheral nervous system. It's just a mess. You can have 20, 30 different things going on that are all driving to this one experience of pain, and you go to a specialist and they're looking at it through a keyhole and they're going, yeah, well, I can help with this. I know what's wrong with it. Pain is an enigma wrapped in a paradox, shoved down to the bottom of the ocean. It's so deep and dark, and so the only way to attack it is to address all fronts at once, because you don't know which one it is. Is it a memorized pain pathway? Is it linked to depression? Is it biomechanical dysfunction? Is it the degeneration itself?
Right.
When I look at someone, I have no idea.
Every time it's like,
every single time. I mean, I can. You do
probably
it
have
long
seen
enough
some
where
trends.
you're like, okay, you can put a hypothesis forward
Sure.
and then test that,
Right.
Right. But you don't know how big of a driver inflammation is in that,
Right.
Right. And so that's why when people come and work with us, we try to take as high level of a picture as possible so that we can look for joint dysfunction problems, we can look for degenerative problems, we can look for inflammatory problems, we can look for nervous system problems, we can look at the entire picture and go, okay, of the 30 possible problems that could be driving this, we're going to address 25 of those right out of the gate, and let's see what happens.
Gotcha.
Usually we bring people's pain down dramatically. Okay, but then if something is left and we've got all those things taken care of, by process of elimination, there's only 4 things that it can be at that point. And so rather than it being an enigma wrapped in a paradox down at the bottom of the ocean, you've created clarity because
Right.
you've laid all the cards out on the table, you've swiped off 25 of them and like, there's only a few left. Let's test it.
Yes.
And then we go after those. And it takes about 6 months to a year to go through that process, but at least there's a process.
Yeah. Well,
because people stay in pain, like everybody up on our story wall, they're all 20-year deep into their chronic pain stories. And it took us 6 to 12 months to get them out.
Yeah.
And so if they would have started at year 1, their chronic pain story would have been 2 years. It's a navigation issue. And so you can spend your entire life wandering in circles, never actually swiping any of those variables off the table and seeking clarity. Okay, which is ultimately what getting a cortisone injection and treating the symptoms and taking an ibuprofen is. You're not testing anything, you're just trying to make your stay in that confusion a little more bearable.
That's a good way to put it.
Because you're not
Yeah.
actually solving anything, you're
Yeah.
not actually gaining any more clarity.
Yeah.
You're not taking any of the cards off the table as to what the problem could be. That's the whole thing, is how can we test and learn as fast as possible to eliminate as many possible problems as we can. That's the whole game with chronic pain. It's always a navigation issue. People feel stuck. They're not stuck. They're lost 100% of the time.
And just to reiterate, I mean, what's going on here is you guys are navigating pain from that level. It's like, let's start somewhere. Let's get things neutralized. Let's put you on a map and in a course to like figure out what this is, which is what people don't have most times. You know what I mean? And to go back to the whole like specialty thing, it's like if I'm going to someone just to see if this bone is out, it's like that's not quite the full picture. Or an opportunity to try something else in order to find out why it's happening.
Yeah, because even if you go to your surgeon and they take an MRI and they find a degeneration, a problem, right? They find a degenerative pattern. You have a bone spur, you have a degenerative disc, you have a bulging disc, whatever it is, right? And they say, well, we can do surgery on this. What they're not telling you is we don't know what percentage of this is the actual problem. Is it 30% of the problem?
Right.
Is it 50% of the problem?
And why wouldn't they know? Just from not being, like, they don't know you, right? They don't know what you've gone through. They don't know how your body's reacting.
The surgeons?
Yeah. How do they not, how do they not know the percentage of where that thing is actually coming
Because nobody knows.
Yeah.
Because it could be 30 different problems, and all they're trained to do is look at it and go, is that surgical? Is that something that is that something that should be fixed? Okay? So they're looking at it from a structure standpoint, not from a pain standpoint. Because pain problems are the enigma wrapped in a paradox at the bottom of the ocean. They're confusing and dark and murky. Surgeons don't go down that route. They go, is there something structural that I can fix?
Oh.
I don't know what's going to happen to your pain. I can make an educated guess, okay?
Based on the structure part.
Based on the structure part, but those two things are only loosely correlated. And so I can fix this, right? But here's the thing, is why did that degenerative condition start in the first place? Because of all the other problems that are driving the pain problem. And so you have 7 problems below that. You have your immobile big toe, your unstable ankle, your unstable pelvis, all shoving load up into your low back. Your low back then has a degenerative condition. Okay, your surgeon looks at it and goes, oh, you have a degenerative condition, we can fix that. They're not telling you, we can fix this, but ... You've got 7 other issues below it that actually created this problem. So when we fix this, we're putting a Band-Aid on it because those other 7 problems are just going to destroy the structure again.
Oh, man.
And so to zoom back out,
Yep.
it's like some people may need a surgery in their journey, right?
Yeah.
But you have to step back, look at the big picture, look at the collective joint dysfunction, look at the degeneration, look at the immune and the nervous system, look at the lifestyle. What are the big drivers there? Let's start to create a path to navigate through this confusion and create a hypothesis, test and learn as quickly as possible so we can eliminate what the possible problems are as quickly as we can.
Right. Yes. And that is a part of the way you guys approach chronic pain here.
Yep.
I like it. Just to, because I don't want to lose this train of thought, the piece about kind of your story, it'd be cool for you to kind of finish that, like, okay, so you were in pain for this long. How did that turn into a line? Like, how did that transition?
Yeah.
Blur the line.
Yeah, so I had 2 discectomies, I had 20 cortisone injections, just all sorts of stuff. None of it was needed. None of it actually solved anything. The one surgery that I did actually need was the 3-level spinal fusion. Okay. They stabilized the unstable vertebrae.
Cool.
Okay. So when they fused down into my SI joint, down into my hips, my SI joint got unstable. And so I was still on a cane for 2 years after my surgery, still on opiates. So it looks like another failed back surgery, right? But from then what I realized was, okay, they wanted to fuse my SI joint, but now we're chasing fusions with fusions. Not a good strategy.
Okay, why? I don't quite know.
Okay, so when you fuse a joint, okay, so the vertebrae, let's come over here.
Cool.
Every segment of your spine moves a little bit.
Right.
Okay, and collectively that makes for a lot of movement. Okay, because you get about 3 to 5 degrees of movement from every single segment.
Cool.
Okay, when you fuse a vertebrae, what you're doing is you're taking out the disc They go in with like hedge clipper things and rip it out. Okay. There's a spinal cord in here too that they need to be careful with. I applaud neurosurgeons. They do great work, usually. So they take out the disc. In my case, they put in a cage. Okay. And they put screws, 2 up, 2 down. And basically what they do, and then they put bone growth material in there. And so they screw these 2 vertebrae together, and then the bone growth grows out around it and makes it 1 vertebrae. It turns 2 vertebrae into 1 vertebrae.
Gotcha.
Okay, and so there's no motion through here.
Because the disc is gone.
Because the disc is gone.
Yep.
Okay, so what happens when you remove motion from one segment is the areas above and below it are forced to do the movement of the area that's no longer moving.
Gotcha.
So you compensate and shove load, stress, and friction above and below that joint.
Okay.
And then those areas tend to wear out faster.
Yep.
So then you just end up with cascading surgeries. Okay? And so that's where I was at. They fused all this. Okay?
Wait, you started having more discs. Your disc things break down.
They fused all the way down into my SI joint, into here.
Okay.
Okay. And so because this wasn't moving, this got unstable. And so my hips started slipping around on my spine, and it was an unstable situation. And so they said, well, we can fuse your hips to your spine, but now we're just chasing fusions with fusions.
Yeah.
Okay?
When does that end?
When does that end?
Yeah.
100%. And so what I did was I went to work on fixing now what was left, which was really joint dysfunction, an instability pattern. And that's how Align was born. That's what we do for people. We fix joint dysfunction. We help them navigate through chronic pain. And so it was getting off of opiates. It was regulating my nervous system, getting inflammation down with nutrition, all that kind of stuff. And just learning how to navigate chronic pain.